Good morning, everyone. So as we have started with chemotherapy, the antimicrobial agent we are going to discuss today is sulfonamides. So these were one of the earliest antimicrobial agents discovered. When they were discovered, initially they were very effective. But over a period of time, many microorganisms developed resistance to sulfonamides. Of late, the use of sulfonamide is very much limited. We shall throw some light on history of sulfonamides. Sulfonamides were the first antimicrobial agents effective against pyogenic bacterial infections. A scientist by name Domag tried using a dye called as Prontosil to treat experimental streptococcal infection in mice, and he was successful. Later, Prontosil was used to cure staphylococcal septicemia in an infant in the year 1933. By 1937, it was clear that Prontosil broken down to sulfanilamide, which was the active compound responsible for its antibacterial activity. Later in the subsequent years, large number of many other sulfonamides were discovered. Coming to the classification of sulfonamides. Sulfonamides are classified depending upon their use. The ones which are used for systemic effect are further classified into short-acting, intermediate-acting, and long-acting. Short-acting duration of action is 4 to 8 hours. It includes sulfadiazine and sulfadoxin. Intermediate acting includes sulfur methoxazole and sulfamoxazole. Their duration of action is 8 to 12 hours. The long-acting ones have duration of action of more than 1 week. It includes sulfadoxin and sulfur methoxazole. The next group is the sulfonamides which are used topically. This includes sulfacetamide, silver sulfadiazine, and mefinite. The other group includes sulfonamide, which is used for special purpose, that is sulfasalazine. This sulfasalazine is used orally in the treatment of rheumatoid arthritis and ulcerative colitis for its anti-inflammatory action. Coming to the spectrum of activity. Sulfonamides are basically bacteriostatic. That is, they do not kill the microorganisms. They inhibit the multiplication of microorganisms. They're effective against few gram-positive and gram-negative bacteria. Susceptible organisms include streptococcal pyogenes, which causes septic infections, streptococcal pneumoniae, which causes pneumonia, Haemophilus influenza, which causes meningitis, Haemophilus ducrei, which causes chancroid, which is a sexually transmitted disease. The other organisms include nocardia, which causes pulmonary disease, actinomyces, which causes abscess, Clematia Trachomatis, which causes LGV, that is lymphogranuloma venereum, which is also a sexually transmitted disease. and toxoplasma, which causes toxoplasmosis. Coming to the mechanism of action of sulfonamides. Now, bacteria need folic acid for various essential metabolic reactions. They synthesize their own folic acid from para-aminobenzoic acid, that is PABA, which is taken up from the medium. Now, sulfonamides, being structural analog of PABA, they inhibit the bacterial folic acid synthesis by inhibiting an enzyme called as folate synthase. Thus, folic acid is not formed. As a result, many essential metabolic reactions suffer. Now, this mechanism was explained in the year 1940 by Woods and Fields. Now, this flowchart will explain the mechanism of action of sulfonamides. As you can see here, the main precursor for folic acid synthesis is PABA, that is para-aminobenzoic acid. Now, this PABA gets converted to dihydrofolic acid. This PABA gets converted to dihydrofolic acid with the help of an enzyme called as folate synthase. Dihydrofolic acid is converted to tetrahydrofolic acid, which is otherwise called as folinic acid, which is the active form of folic acid, by the help of enzyme called as DHFR, that is dihydrofolate reductase enzyme. This tetrahydrofolic acid is utilized for the synthesis of DNA. Now, sulfonamides, they inhibit the first step here, that is, they inhibit folate synthase enzyme, and thereby they prevent the synthesis of folic acid from PABA. Kindly mute yourself. Now, human cells are not affected by sulfonamides because even though human cells require folic acid, it will take up the folic acid which is preformed in the diet. So as a result, sulfonamides will not affect the human cells. Now it is seen that in the presence of pus, sulfonamides are less effective. The reason being pus contains a lot of purines, thymidine, and it is rich in PABA, which antagonize the action of sulfonamide. So sulfonamides are less effective in presence of pus. Now, every microorganism, they develop various methods by which they develop resistance to many antimicrobial agents. So even with sulfonamides, you will see a lot of many organisms which have developed resistance. The probable mechanisms are: one is by increasing the production of PABA, that is, the bacteria start producing more para-aminobenzoic acid, which will antagonize the action of sulfonamide. The next mechanism is the bacteria start producing folate synthase enzyme, which have less affinity for sulfonamides. The third being, bacteria may develop alternative pathway for the folate metabolism. So by these mechanisms, organisms develop resistance to sulfonamide very easily. Coming to the pharmacokinetics of sulfonamides. Sulfonamides are rapidly and nearly completely absorbed from the gut. Their bioavailability varies from 70 to 100%. They are plasma protein bound, and this plasma protein binding varies from compound to compound, and they're widely distributed in the body. They undergo metabolism in the liver. The major metabolite formed is the acetylated metabolite, which is less soluble in the urine, and therefore it gets precipitated, resulting in crystalluria, which is a major drawback of sulfonamides. Coming to the individual drugs, the first one is sulfadiazine. It is the prototype drug. It is rapidly absorbed from the gut and it is rapidly excreted. and therefore its duration of action is shorter. Its plasma protein binding is 50%. It crosses the blood-brain barrier easily and attains high concentration in the CSF. Therefore, it is preferred in the use of meningitis. The side effect being crystalluria. This is because of the acetylated metabolite, which is less soluble in the urine, which gets precipitated. The next one is the sulfur methoxazole, which is an intermediate acting drug. It is slowly absorbed and slowly excreted, and therefore its duration of action is intermediate, its T-half being 10 hours. It is the preferred compound for combining with trimethoprim to form a compound called as Cotrimoxazole. Now, they are combined together because their T-half are similar. Sulfamethoxazole with trimethoprim is commonly used in the treatment of Pneumocystis jirovecii pneumonia, which is common in AIDS individual and in neutropenic individual. The adverse effect being again crystalluria. The next drug is sulfadoxin. Sulfadoxin and sulfamethopyrazine are longer acting because they are highly plasma protein bound. Their duration of action is more than 7 days. Sulfadoxin is used in combination with pyrimethamine for the treatment of chloroquine-resistant malaria and toxoplasmosis. Now, sulfadoxin is the preferred compound to combine with pyrimethamine because, again, both of them are longer acting and their T-half is similar. Adverse effects of sulfadoxin is serious cutaneous reactions. The next, we have the topical sulfonamides. The first one is sulfastamide. It is highly soluble. It attains high concentration in the anterior segment and aqueous humor of the eye. Therefore, it is very commonly used in the treatment of ocular infection caused by chlamydia. It is available in the form of drops and eye ointment. The next topically used drug is Mefinite. It is not a typical sulfonamide because its structure differs. It is used only topically, and compared to sulfonamide, Mefinite has two advantages. One is it is active even in the presence of pus. Second, it is effective against Pseudomonas and Clostridia. Therefore, Mefinite is used topically in case of burn dressing to prevent infection. So whenever you have burns, Pseudomonas infection is very, very common. So to prevent the development of infection, regular burn dressing can be done with Mefinite. But if the infection is already existing, then Mefinite does not work. Adverse effect of Mefinite would be burning sensation when it is used topically over raw surface. The next drug is silver sulfadiazine. It is also topically used as 1% cream. It is effective against some of the bacteria and fungi. It releases silver ions, which are responsible for the antimicrobial activity. Again, this is used topically for burn dressing and dressing of chronic ulcers to prevent any infection. If the infection is already existing, it may not be effective. Side effect would be again burning sensation, which is seen with Mefinite also. The last sulfonamide is sulfasalazine, which is used for special purpose. It is used orally in the treatment of an inflammatory bowel disease called as ulcerative colitis and autoimmune disorder, that is rheumatoid arthritis. Here it is used not for its antimicrobial activity, but it is used for its anti-inflammatory property. It will be dealt in detail when we take up the treatment of inflammatory bowel disease and the treatment of rheumatoid arthritis. Coming to the uses of sulfonamides. Sulfonamides are used in the treatment of trachoma caused by Clematia Trachomatis. Here we prefer using sulfastamide sodium. Silver sulfadiazine and Mefinite, they can be used topically for burn dressing and dressing of chronic ulcers. Sulfasalazine can be used orally for its anti-inflammatory property in the treatment of ulcerative colitis and rheumatoid arthritis. Sulfadoxin in combination with pyrimethamine is used in the treatment of toxoplasmosis and chloroquine-resistant malaria. Sulfur methoxazole with trimethoprim, which is called as cotrimoxazole, is used in the treatment of pneumocystis jirovecii pneumonia, which is more common in HIV individuals and neutropenic individuals. Now, sulfonamides are known for their adverse effects as well. They have many adverse effects, the most common being urinary disturbances. Because the acetylated metabolite is less soluble in the urine, it gets precipitated, resulting in crystalluria, hematuria, and urinary obstruction. Sulfonamides can also cause anemia and granulocytopenia. They can cause fever, skin rashes, dermatitis, photosensitivity, urticaria, and other allergic reactions. They can cause GI disturbances like nausea, vomiting, and diarrhea. Sulfonamides are known to cause some skin problems like Stevens-Johnson syndrome and exfoliative dermatitis. Sulfonamides precipitate hemolysis in patients having glucose 6-phosphate dehydrogenase deficiency. So you have a list of drugs which precipitate hemolysis in G6PD deficiency. So one of it is sulfonamide. Sulfonamides can also precipitate kernicterus in newborn because of the displacement of bilirubin from plasma protein binding. As a result, there is increased concentration of bilirubin which can easily cross the blood-brain barrier and affect the brain in the newborn, resulting in kernicterus. Coming to the drug interactions. Sulfonamides are known to potentiate the action of sulfonylurea, that is tolbutamide, which is a drug used in diabetes, oral anticoagulants like warfarin, hydantoin like phenytoin. The problem mechanism is by inhibiting the metabolism of these drugs. So as a result, when sulfonamides are combined with tolbutamide, there is increased risk of hypoglycemia. When sulfonamides are combined with warfarin, there is increased risk of bleeding. When sulfonamides are combined with phenytoin, there is increased risk of phenytoin toxicity. Sulfonamides should not be combined with methotrexate also, because sulfonamide will displace the plasma protein binding of methotrexate, resulting in its toxicity. Now coming to cotrimoxazole. So as I have already mentioned, it is the combination of sulfonamide with trimethoprim. So it is the combination of sulfur methoxazole with trimethoprim in the ratio of 5:1. It is a fixed dose combination. Now why these drugs are combined together? The rationale of combining these two drugs are they have similar T-half. So their T-half is around 10 to 11 hours, which is similar. Together, they cause sequential blockade, resulting in synergistic combination. So it is an example of synergism. There are a lot of advantages of this combination. The first one being bactericidal. Individually, these drugs are bacteriostatic, but when they are combined together, they become bactericidal. Next, coming to the spectrum of activity. Individually, they are narrow spectrum, whereas the combination has broader spectrum of activity. The third being, individual drugs are more prone for resistance, whereas when the combination is given, the chances of development of resistance is less. Now this flowchart will explain the sequential blockade caused by cotrimoxazole. So as I have told you, the main precursor for folic acid synthesis is para-aminobenzoic acid. Now the para-aminobenzoic acid gets converted to dihydrofolic acid with the help of folate synthase enzyme. Now this first step is inhibited by sulfonamide. Dihydrofolic acid gets converted to tetrahydrofolic acid with the help of dihydrofolate reductase enzyme. Now this enzyme is inhibited by trimethoprim and pyrimethamine. So when you combine sulfamethoxazole with trimethoprim, sulfamethoxazole will inhibit the first step, that is folate synthase enzyme. Trimethoprim will inhibit the second step, that is DHFR enzyme, resulting in sequential blockade. When you combine sulfadoxin with pyrimethamine, sulfadoxin will inhibit the first step, that is folate synthase enzyme. Pyrimethamine will inhibit the second step, that is DHFR enzyme, resulting in sequential blockade. And this is called as synergism. Now coming to the spectrum of activity, as I have told you, this combination is bactericidal and they have wider spectrum of activity compared to the individual drugs. Cotrimoxazole is effective against Salmonella typhi, Serratia, Klebsiella, Enterobacter, Yersinia enterocolitica, and Pneumocystis cerevisiae. It is also effective against Staph aureus, gonococci, meningococci, and H. influenza. Now, the development of resistance to cotrimoxazole is less, but still organisms may develop resistance to cotrimoxazole by producing DHFR enzyme with less affinity to trimethoprim. Now coming to uses of cotrimoxazole. Cotrimoxazole is the drug of choice in the treatment of Pneumocystis cerevisiae, which causes pneumonia in HIV individuals and neutropenic individuals. Cotrimoxazole is also used in the treatment of shigellosis, typhoid, urinary tract infections caused by E. coli, if it is an acute uncomplicated urinary tract infection, or it can also be used to treat chronic and recurrent UTI, and also in prostatitis because trimethoprim gets concentrated in the prostate. The other uses of cotrimoxazole are plague, nocardiosis, respiratory tract infection, which includes upper respiratory, lower respiratory, chronic bronchitis, and otitis media caused by streptococcus. It can also be used in the treatment of chancroid, which is a sexually transmitted disease caused by Haemophilus ducrei. Cotrimoxazole is also effective in brucellosis and listeriosis. Coming to the adverse effects of cotrimoxazole. Now, because of the sequential blockade, there may be folic acid deficiency. This results in megaloblastic anemia. So this is one of the commonest side effects of cotrimoxazole. The other adverse effects include leukopenia, granulocytopenia, fever, nausea, vomiting, damage to the kidney, vasculitis. Kindly mute yourself. And in elderly patients, there is increased risk of bone marrow toxicity. Now coming to the preparations, as I have told you, sulfamethoxazole is combined with trimethoprim in the ratio 5:1. That is 5 parts of sulfamethoxazole is combined with 1 part of trimethoprim. So the usual combinations are 400 milligram of sulfamethoxazole with 80 milligram of trimethoprim, or 200 milligram of sulfamethoxazole can be combined with 40 milligram of trimethoprim. So this is about sulfonamides. The next topic is the drugs used in the treatment of sexually transmitted diseases. The first one is gonorrhea, which is caused by gonococci. Here, the drug of choice is amoxicillin. You can give 3 grams single dose, or you can use ampicillin 3.5 grams single dose. The alternative drug will be cefixime 400 milligram single dose. The next is syphilis caused by Treponema pallidum. Here, the drug of choice is benzathine penicillin, which is a long-acting penicillin. So if it is primary syphilis, you can give benzathine penicillin 2.4 million units intramuscularly, 1 to 3 weekly you can give. If it is late syphilis, then you can use benzathine penicillin 2.4 million units intramuscularly every week for 4 weeks. The alternative drugs will be doxycycline, erythromycin, ceftriaxone. Next, coming to Clematia trachomatis, which is a disease caused by Clematia trachomatis causing LGV, that is lymphogranuloma venereum. Now here the drug of choice is azithromycin. You can give 1 gram every week for 3 weeks. The alternative drug will be doxycycline, which is a tetracycline. You can use 100 milligram twice daily for 3 weeks. Then we have chancroid, which is caused by Haemophilus ducrei. So here the drug of choice is ceftriaxone, 0.25 grams intramuscular single dose, or alternative drugs will be azithromycin, erythromycin, or doxycycline. Then we have genital herpes, which is caused by herpes simplex. So here the drug of choice is acyclovir. You can give 200 milligram 5 times daily for 10 days. Alternative will be valacyclovir or famciclovir. Then we have Trichomonas vaginitis caused by Trichomonas vaginalis. Here the drug of choice is metronidazole 2 gram single dose, or you can go for tinidazole 2 gram single dose. Now coming to the expected questions from this topic. There may not be any long essay from this topic, but short notes or short answers are frequently asked. The first one is explain the sequential blockade with example. So you need to explain with the flow chart. You can take example of sulfur methoxazole with trimethoprim, or you can explain sulfadoxin with pyrimethamine combination. The next question is a rationale of combining sulfur methoxazole with trimethoprim. So you have to explain the reason why these two are combined and what are the merits of this combination. The next is cotrimoxazole, short note. So here you have to explain what is cotrimoxazole, their sequential blockade, the merits of this combination, uses, and their adverse effects. Then you have the drugs which are used in toxoplasmosis. Then you have sulfasalazine, which is the drug used for rheumatoid arthritis and ulcerative colitis. So it can be asked for a short note. Then you have topical sulfonamides. So you need to talk about silver sulfadiazine, sulfostamide, and Mefinite. Now, before I end the class, I have a small announcement to make. You will be having second internals starting from July 1st. The pattern and the portions will be announced by the respective departments. So in pharmacology, the portions will be central nervous system, respiratory system, GIT, autocoids, and hormones. And the pattern will be the regular pattern where you have long essay, short notes, and short answers. And followed by this, in July 2nd week, you will have a pharmacology viva on theory. Thank you.